This video is going to focus on the difference between SVT with aberrancy and ventricular tachycardia. So first, what is aberrancy? Aberrancy means abnormal conduction. So here's the thing, guys. If you remember back to last semester, I taught you that a sinus rhythm is always narrow, a ventricular rhythm is always wide. We now know that that's not necessarily the case because there are other things that can cause the ventricular complex, i.e. the QRS complex, to widen even when it's not a ventricular in origin type of rhythm, such as a bundle branch block. So it's important that we can differentiate between a atrial arrhythmia with something weird going on, i.e. aberrancy, abnormal conduction, and a ventricular rhythm when we are trying to assess and treat our patients, because the treatment modalities are very different. As we learned last semester, the difference in the treatment of Vtach with the pulse versus SVT with the pulse. So where do we start? Well, the first thing to think about is obviously going to be the QRS duration. If it's a wide complex, let your mind wander towards the ventricular side for a moment, but let's make sure of a few things. So definition of ventricular tachycardia. Vtach has no P wave, right? Because it's ventricular in origin, so there's no true atrial depolarization, and if it does happen, then it's normally hidden within the QRS complex, so you're not going to see it anyway. So we have a wide complex for ventricular arrhythmias with no discernible P wave. Normally, a ventricular arrhythmia is going to have a regular R to R interval. That's not a requirement, that's just a normal thing. So think on the SVT side, AFib, A-flutter, some type of atrial abnormality, arrhythmia. Normally we're looking at a narrow complex. Obviously, as we mentioned a minute ago, there are some things that can make that complex widen out. So as a general rule, if it's wide, think ventricular until proven otherwise, but try to prove it otherwise. And what I mean by that is don't get distracted and say just because it's wide it's ventricular and I'm not going to do any digging into the EKG. So if you look at your state protocol and you look at the American Heart Association algorithms, they don't differentiate between SVT and Vtach very well. And they actually don't even use those terms. They say a narrow complex tachyarrhythmia and a wide complex tachyarrhythmia. You're going to go wrong if you just think of it in those terms. So a couple of things that we can do to try and figure out, is this ventricular in origin or is this maybe an atrial arrhythmia that is wide for whatever reason? And I can't see a P wave because a junctional tachycardic rhythm with a left bundle branch block would follow all the same rules as Vtach. So first thing to think about is your QRS axis, your ventricular axis. We've learned about axis, we know how to use axis. So in a ventricular in origin rhythm, oftentimes, not always, but oftentimes you're going to see extreme right axis deviation. And if you look on that axis deviation chart that is on your blackboard, it's actually the Bob Page axis deviation chart, then you're going to see that when you have ERAD, extreme right axis deviation, it says two things. It says either no man's land, it says axis indeterminate, or it says ventricular in origin. And any of those things really could be true. More than likely, if you have ERAD, it's going to be ventricular in origin, because think about it. Energy is moving in the exact opposite direction as expected through the ventricles. What could cause that? Well, what if the energy started at the bottom of the ventricles and made its way back up towards the AV node? That would change the ventricular axis and make it up and to the right, way high, right? Instead of down and to the left like it should be. So that's a good place to start. Always check your axis. Do you have to have ERAD to have a ventricular in origin rhythm? No, you do not, because if the ectopic foci, or the pacemaker in this case, that is taking over in the ventricles is high in the ventricles, especially up near the AV bundle, then you could have fairly normal ventricular depolarization, and therefore you could have a fairly normal looking axis. So it's not a 100% thing, but it's definitely something to think about, is your axis. The second big point that I want to make for you is called Josephson's sign. Josephson's sign. I don't have a way to draw or anything on my little video here. We will talk about this more specifically in class on Wednesday, but I encourage you to go ahead and Google that and see what you can find. So Josephson's sign is a notching on the downslope of the R wave. And normally we see this more predominantly in your precordial leads, V1, V2. That's a great place to go to look for it, but it could be anywhere. So Josephson's sign, and that's Joseph's son, if I'm not saying that clearly, Joseph's son sign, is very indicative of ventricular tachycardia. Again, nothing's 100% when we're talking about EKGs because it's all open to quote-unquote interpretation, but that's a really good thing to think about. So if you have Josephson's sign and you have ERAD, there's a really good possibility that you are treating a ventricular in origin rhythm. There's no 100% surefire way to make sure that we're looking at ventricular versus atrial really ever. But these are some tricks, some techniques that we can use to help differentiate between the two so that you can better assess and treat your patient.